Hi, everyone. Welcome, welcome. We're just waiting for a few more folks to come in from the waiting room. Great. Hi, everyone. Thanks so much for joining us. My name is Kim Whitmore. I'm just going to get my slide sharing here. We'll get started. Great. Are you guys all hearing and seeing me okay? Wonderful. Welcome, everyone. My name is Kim Whitmore. I am the current director of the Break Exchange, and I'm an assistant professor in the College of Nursing at Marquette University. And I'm so excited to be co-hosting this webinar with the Arch National Respite Network and Resource Center. So I want to invite Jill Kagan to share a few words about Arch and provide a welcome from Arch.
Thank you very much, Kim. I'm Jill Kagan, director of the Arch National Respite Network and Resource Center. And as many of you know, we're a federally funded training and technical assistance center, and we're very excited to co-host the webinar today. Arch's and my own personal history in supporting crisis nursery respite goes back many years, and we're really delighted to be able to share what we've learned over the last 30 years about the powerful impact that these services can have in supporting families. We're also excited that this webinar will be featuring Providence House, as you all know, a crisis nursery in Ohio. And it has been recognized by Arch as an innovative and exemplary respite service through our national initiative, which makes me especially proud to welcome them here today. So thank you, Kim, for the great collaboration we have through the Break Exchange, and we're really looking forward to the presentations today.
Great. Thanks so much, Jill. Always great to work with you. I just want to take a moment to recognize that November is National Family Caregivers Month here in the United States. So I think that's something for us to celebrate and remember as we approach this upcoming month, that we make sure to always recognize, assist, include, support, and engage family caregivers in our work. And then I also would love to just take a moment to stand in solidarity with our partners and colleagues that are in Ukraine, or our international colleagues, especially that are surrounding Ukraine and providing support and services to those impacted by the ongoing war in Ukraine. So if we could just take a short moment of silence to recognize our colleagues and stand with Ukraine. Thank you for that. So for those who are new to the Break Exchange webinar series, I want to just share a very short overview of what the Break Exchange is. So Break stands for Building Respite Evidence and Knowledge, and we are an international group of researchers, respite providers, agencies, and individuals who are committed to building a culture of evidence-based respite care. Break Exchange was founded with a great partnership between the International Short Break Association, Arch, Shared Care Scotland, and Marquette University. There's lots of great benefits of joining the Break Exchange. So if you're not officially signed up for the Break Exchange, and it's free to join, we encourage you to do so. You have the opportunity to connect with a global network. As we mentioned earlier, we do have monthly networking hours, the second Monday of every month, which are a ton of fun, very informal, and a great way to connect and hear what's happening around the world. We currently have more than 292 members from 19 countries that are signed up for the Break Exchange. So continuing to grow that each year. We're very excited to have collaborators all around the globe. It's a great opportunity to learn about evidence-based respite care practices and research that's happening, and also share what you're doing. So this is a great forum for you to promote and celebrate the great innovative things that you're working on, whether that's evidence-based practice initiatives or research. And there's lots of ways to share. We have a monthly e-newsletter that we highlight and feature programs and projects. We also have places on our website we can promote. We can leverage our social media and email networks. And also you have the opportunity to present in our webinar series like today. And then one of the things that we are most excited about for the Break Exchange is the opportunity to promote collaboration. So if you are someone who is a researcher looking for a program or practice partner to connect with, or if you're running a respite program and you have some questions or ideas that you'd love to have somebody come in and help you evaluate, or think there's a great research idea, this is a place where you can leverage this exchange to identify partners. So ways to promote that is by creating your own member profile, and then you can actually search our member database for partners who are doing similar work or have interests that you're aligned with. So please stay connected. You can connect through social media, through our website. You can join our listserv, fill out your member profile, and at any time, feel free to email us as well. And then I'll just close with just a reminder to all of us that self-care is important for all of us as well, and the work that we do to support caregivers, and that self-care can be lots of different things. So it's not just about taking a rest. There's lots of ways to think about how we provide self-care for ourselves and promote that amongst those that we work with. So with that being said, I'm going to briefly introduce the topic for today's webinar and our speakers, then I'm going to turn it over to them. We're so excited to have the opportunity to learn more about Crisis Nurseries. Our webinar title is Keeping Kids Safe and Families Together. Crisis Nurseries provide non-custodial crisis respite for families with young children who are addressing issues which may impact their child's safety. We have Natalie Leek, who has been the CEO and president of Providence House since 2001. Amy Mills from the Center for Crisis Nursery, the manager of the Center for Crisis Nurseries. We're also delighted to have Sandra Fierman and Susan Summers, both of whom are senior ARCH consultants who have experience working in a crisis nursery in Washington State and in evaluating crisis nursery services. So with that being said, I am going to turn it over to our presenters and they will share more, and feel free to use the chat to ask questions and I'll help moderate that as.
Okay, thank you so much, Kim. I'm Cassandra Furman. I work with the Arch National Respite Network and have for 20 years. But before that, I was my friend Susan Summers and I in Oregon, not Washington, helped run a crisis nursery called the Oregon Relief Nursery. And this was in Eugene, Oregon, and this is in the 80s. I'm going to share a quick story, and then I have a few slides before I pass it on to my colleague, Natalie Leek, colleague and friend, I would like to say, who's going to tell us a lot more about different crisis nursery models. But I'd like to begin by telling you that I was a good mother. I was a very good, loving mother. My son was 4 months old when he developed a life-threatening illness, and he had surgery at Children's Hospital in Brisbane, Queensland. I lived in Australia at the time. I was alone because my husband had been at sea. We had a fishing trawler. I brought him home after a week in the hospital and didn't sleep for about 4 days. He's crying constantly. I'm terrified. I'm a new mother on my own. And after a few days of no sleep, I'm feeling on the verge of throwing the person I love the most in the world, throwing him against a wall. I'm imagining this in my brain because I'm developing psychosis, I would say, from not sleeping. Tom is crying so loudly, my baby, that my neighbor hears him, comes rushing over to my house, doesn't knock, walks in and says to me, "Give me that baby, you go to bed." It was sort of startling. Well, thank goodness I handed her Tom. I went to bed and got some sleep. Without knowing it, I was receiving crisis nursery services. I was in a moment of crisis. I put my child at risk, not because I was a bad parent, but because I was incapable of dealing with the stress. And I got help. The help was imposed upon me, I will say, but thank goodness, because I don't know what might have happened. Not all families have a neighbor or a family member or someone available to them. I'm a middle-class person, educated, And yet I was on the verge of doing the unthinkable. I think what crisis nurseries offer is they provide emergency shelter and respite services to families who are experiencing a crisis. Now, that crisis care in itself is absolutely necessary for families. We need breaks to be able to deal with the crisis, but it's not fully sufficient. Most crisis nurseries, you will find, provide short-term care for children when their families are in a state of crisis, but also make sure that wraparound services are also available to them. So for me, yes, I needed sleep. I also needed a plan for how am I going to continue to get sleep and how am I going to continue to take care of my baby. So the service, the crisis care, is not just for the child, but crisis care is usually provided for the whole family. So the parents get a break and the child gets a break and is in a safe spot. And then the family can work on the issues. So basically, crisis nurseries are programs that are embedded in their communities. They often offer wraparound services, and they're available so that we can avoid having to use foster care placements, because that would be completely inappropriate in my situation and in many other situations where we end up using foster care. So basically, crisis nurseries provide emergency shelter to children and families who are experiencing a crisis. It's delivered to the whole family. It's embedded in the community. So could you go on to the next slide right there? Thank you. I'm going to give you a very, very brief history of crisis nurseries. Clearly, crisis care has been occurring forever. Families and communities have taken care of their own when situations called for help. But formally, we began seeing programs emerge in the 60s and 70s that formally offered crisis care outside of families. And in the 80s, there was a federal funding source called Temporary Child Care Act. And that's the one Susan Summers and I actually tapped. Susan was the one who found them, tapped into them. And they were funding respite services, including what they were calling crisis nurseries. I'm not sure how the term nurseries got in there, but we realized, hey, we're providing this kind of care. So we were able to tap into that funding. And so the term crisis nurseries is used quite often, even though nurseries can serve, I've heard of programs serving people up to 21 years of age in crisis care. I'm also hearing of programs serving adults who with disabilities or who are in a state of crisis, whose family may need the break. So the focus is on mental health and family stability, keeping families together and safe. There is additional funding that could be tapped into now. Family First Preservation Services, Title IV funds can be used and sometimes are used for services that can help families stay out of foster care. So crisis nurseries look different across the country. And I'm going to let Natalie talk about the different crisis nursery models that she's aware of and how Providence House has responded to the need for crisis care. Thank you.
Thank you, Cassandra. Thank you, everyone, for having us today. And Jill and Susan, great to have you with us as well. So while we're going to focus a little bit on the Providence House crisis nursery model, as Cassandra said, there are about 60 nurseries actively operating currently in the US and Canada that we're aware of. And we all look a little different. We are connected together. We'll talk about the Center for Crisis Nurseries in a bit. I want to thank Vanessa Behan, who's on the call with us today, Amy Vega, who's a partner, Marilyn Gisser, who is interested in opening a nursery, and our researcher, Professor David Crampton from Case Western Reserve University. As we talk with other nurseries and understand our models of care, we vary. And as Cassandra said, we're embedded in our community. So we're responding in the ways that the communities that we serve need us. Lengths of stay are different. Some are 48 to 72 hours. Some are daytime only. Some are overnight. At Providence House, children can stay up to 90 days in a way to be responsive to families that are seeking inpatient treatment services or extended lengths of stay due to housing crisis or unavailable housing in our community. Age ranges, as Cassandra said, also vary. Typically, birth through 5 was, the nursery model. But again, as we're responding to community need, our program goes up to the age of 13. We know programs that are going up to 18. And the children we're serving and the types of care that are delivered are not just crisis respite services for typically developing children or children who've experienced trauma. It's also children who have disabilities or medical conditions or a hybrid of these services so that we're truly able to serve children of all types and from all families in our programs. So, again, depending on the community, the need, and frankly, the legislative and licensing guidelines, state by state, nursery models do look slightly different, but the commitment is to keep children safe and their families together, resolving that crisis so that at the end, they are healthy and safe and able to remain together in their communities. So I'm going to give a quick overview about Providence House. We are one of the nation's longest operating crisis nurseries. We currently have a 30-bed campus that serves about 300 to 350 children a year and are opening another campus on the east side of our city that will be operating by next summer. The reason being, and you'll see our service levels, while we're serving about 300 to 350, we have had for 4 years running over 400 children waitlisted or unserved, needing our program services. We are licensed through the Department of Job and Family Services in our state as a crisis care facility. New quality residential treatment program requirements for residential children's facilities were launched in 2021, again aligned as Cassandra highlighted with the Family First Preservation Services Act. So these are new federal standards from HHS flowing down into residential centers across the US. In Ohio, crisis nurseries are also included in that additional certification. As you can see, we have really strived to sort of break through the mythology that we just rock babies. We are an accredited, evaluated model for child maltreatment prevention and family preservation. So we are, as I mentioned, licensed. We are also a certified behavioral health provider through our Department of Mental Health and Addiction, a Medicaid behavioral health provider. And you can see, additionally CARP accredited and transparent in terms of our supporters, in terms of our stewardship of the gifts that we receive. Our operating model, we didn't put the slide here, but our operating model, so that you're aware, is about 75% privately funded, the balance through a stream of federal, local, or state support from public sector. So again, as with all crisis nurseries, our mission is to keep children who are at risk safe by having them stay with us while we support their family through crisis, and strengthening our communities through education, advocacy, and support to end maltreatment. We're really dedicated to support that is accessible, it's impactful, and it truly is focused on helping families succeed. As Cassandra said, I'll give you a little bit of an overview about kind of how we sit a little differently in Ohio in terms of a lot of advocacy we've done on our crisis nursery regulations. These are residential children's facilities, typically center-based with non-custodial admission by the parent. So these are voluntary admissions by the parent. Only children stay in these facilities. Parents are typically addressing their own needs in crises, receiving services elsewhere, or housing and community safety is a concern. We embed family preservation deeply into traditional crisis residential services for children. We're working intensively with the family throughout a child's stay. And our primary focus is on maltreatment and trauma prevention, providing a safe space for these children to be temporarily away from home while their parent can focus on receiving the services they need and strengthening their practices and nurturing caregiver skills. We, as Cassandra said, there's always been a role crisis nurseries played as an alternative to foster care. There is now a national focus, as you know, a lot of the research is coming out, and there is a realization that removing children from their families isn't the best idea for children and families, particularly when we know that many of the children being removed in these instances, these are poverty-related dependency issues that could be addressed through supportive services. So these are non-custodial admissions. Last year, 100% of the children we served successfully reunited with their families. Again, we talked about children 5 years old. We have changed licensing standards in Ohio 3 times to get up to 12 years old. So preteen, anyone under 13. Many states have 72, up to 48, 72 hours. Some have 30 days. We have now modified our licensing rules, just published this week, for 90 days lengths of stay for any child admitted. Children can also be admitted through first responders or public service agencies for up to 14 days in emergency situations. We call it Juvenile Rule 6 in Ohio. Just to give you a sense of the context of our community, Cleveland, Ohio is where we're located. High rates of child poverty, high rates of infant mortality, working poor families, which is compounded now in the current economy. And Ohio really is not the leader in its investment in child welfare or prevention services. So we're really operating in a very at-risk community, trying to be as responsive as we can be. And some of the stats that many of us in child welfare know around the harmful and costly epidemic of maltreatment and public system involvement in family investigation. So you'll get this deck, you can read through, but certainly we're talking about lifelong impacts for very young children without this level of intervention for their family focused on preservation. Highlighting, because kind of the closest apple to our orange is foster care. Where do you put a child who's in an unsafe situation? As I mentioned, most children in custody are being removed for poverty-related dependency issues, and there is a national focus to shift on intervention and family services to address this. Giving you just some basic national standards here, but we know that the outcomes for children being removed from their families and placed in foster care are not good. Youth are aging out into adult services at very high rates, and we're actually spending more on them in these services as adults than the money we spent while they were in foster care. When we look at the children, even just open case children, so children already engaged in some level of oversight by CPS in our community, those children not entering foster care represents about $10 million saved in our foster care system. So again, we talked about 100% of our families reunite. Our average length of stay in our nursery, while we have 90 days, is about 25 days before the family reunites. A significantly shorter period of time with families apart from one another, and high rates of reunification in those calculations. We also, and Professor Crampton, who's joined us today, have done studies on our program and we hope to be embarking on a new one here shortly. But one of the interesting findings in our last research was that it really looked at the racial disproportionality, which many of us are aware of in child welfare and other supportive systems. And we found that the kind of the reverse outcome for our families from public system engagement, where Black and families of color, multiracial families were the most engaged in our program and the least likely to have their kids enter foster care following services. And we are seeing that, even long-term in the research, over 80% of our children remained out of foster care. So when you look at how we approach, and many of our nursery partners approach, these are multi-generation focused programs, really with strength-based, trauma-informed approaches from the minute the phone rings. And that includes families on the waiting list. We are offering case management, even if they're waiting to get in. We are a data culture. Providence House is really committed to quality outcomes, pursuing evaluation and external evaluation of our program, and continuously innovating our approach to meet community need and improved outcomes. And we know that we're a niche service. We know our core competencies are really on holistic care for children and the engagement of their families, connecting them to links in the community that can help them succeed long term. So, we were talking briefly, Susan and Cassandra and I, about, a lot of times when nurseries open in new communities, there's a fear in the community. Here comes another organization. We're all competing for the same dollars and clients. But we really kind of turn that around on itself and say, actually, we're improving service connection. Families are coming to us with their children, and we're linking them back out to community to say, these are the organizations that are going to provide you the services that you need for long-term stability, whether that's treatment, housing, education, employment. So we call ourselves kind of a super connector in that way. And we really acknowledge and respect the brave and difficult choices our families are making. They're bringing the most, the biggest treasures in their lives to complete strangers in a moment of true need. And that is a hugely brave thing to do. And they are desperately seeking support and stepping forward to get that. As you mentioned, we were opened in 1981. Our family preservation crisis nursery model is not something that happened overnight. We actually were in operation for over 20 years before we launched intensive family services. We were doing primarily the children's shelter and care work, and then moved into family engagement around 2004, 2005, and trauma-informed care and certification in the later part of 2000s. We've expanded our program and facilities 4 times on our West Side campus, and as I mentioned, we'll be opening another new crisis nursery facility on the other side of our city in the spring of 2023. So as I've highlighted, our services really for children are about the whole child: physical, emotional, developmental, educational. School-age children remain connected with their schools, and we interface with them. So we are supporting up to 30 children, soon 50 at a time, in our crisis nurseries for up to 90 days. We do have 24/7 awake childcare staff providing direct care and support. And they are, we use an assigned childcare model. So while we team care during the day by age and development, we assign childcare providers in a ratio of 1 adult to 5 children, 24 hours a day awake, to really be that surrogate parent. They are a peer mentor to the parent while their child stays with us. And they are the person, I always say, they're kind of the boo-boo kisser, the person that tucks you into bed. And we also do medical care and monitoring on our campus. All of our children receive well child exams. In our current world, they are also pre-screened for COVID, and we are doing ongoing monitoring of children who have specific medical needs. While most of our clients, the majority in fact, are self-referred, and most of our families are referred by a family who used our program, we do have some contracted partnerships with public agencies where we're really filling a very needed gap in our community. So our local CPS uses us for emergency placements of children whose foster care has been disrupted, or there is an emergency removal by police or first responders in a dire situation. We also provide children's shelter through our local alcohol, drug, mental health board for families who would otherwise refuse inpatient psychiatric or sobriety treatment if they didn't have somewhere for their children to be. And so those are just some examples of how public sector interface is actually preventing foster care and improving outcomes for the parent and the child. Our family center, these are family rooms, they're comfortable spaces. This is where we're doing all of our case management and referral, parenting support and education, medical skills training if a parent has a child with an ongoing or chronic medical condition. We do family trauma services, including trauma screening of the parent and child. And we run a 12-month aftercare program where we remain with families who graduated from our program for up to a full year, longer if they need. If they're done with us in 6 months, that's okay too. But we know that re-entry can be so challenging for families, and we continue to be a resource for them. These family center services are required in our program. So parents who admit their children are required to engage in these services at minimum 2 to 3 times a week. And it is a requirement for ongoing admission of their child. And family engagement in these services is extremely high in our program. And they do really, it's not just because they have to, it's because they want to. We also have moved into community-based services, which really, started before COVID and got legs under it big time during the pandemic. So we are a community resource from other provider partners for basic need item referrals. We've served over 300 families from over 30 different partner agencies for things like diapers, formula, children's clothing. And we also do take our family center services out into the community with a community education and resiliency program that is delivered in Boys and Girls Clubs, our local public housing, libraries, elementary schools, where we're working with cohorts of families who may not need the nursery yet, but if we can give them those family center supports ahead of time, hopefully we can prevent even needing admission to the nursery. We also deliver respite services to families who have used our program, but may need an additional couple days, 3 to 5 days for sobriety maintenance or mental health maintenance. A lot of grandparent kin providers use our respite service just for a break or to address their own medical needs. As I mentioned, we work with a lot of partner agencies. So we last year partnered with over 130 providers in our community, sending or receiving referrals from one another to make sure that those families were getting the services they need and children were safe. We also do a lot of community education and outreach, as well as public policy and advocacy work at our local, state, and even federal level. So a little bit about our clients. Almost 90% of our clients are living at or well below the federal poverty line. 20% had no cash income before coming to us last year, and a significant history of trauma and violence for both the parents and children who come to our program. So trauma is a big issue for our families. Interestingly, almost 90% of our parents self-report a history with child services, either themselves as children or with the children currently with us or children that had already been placed in foster care. When we talk about respite services, it's 31% of our families came for respite. You can see mental health, overwhelmed parent, sobriety, maintenance, and they're reaching out primarily for lack of resources to meet basic needs, unsafe or unsafe housing or homeless, family medical crisis, mental health crisis, witness victim of violence are a lot of the reasons that our families are coming to us with their children. I think this is probably one of my favorite things when I talk about our program. Nearly 70% of our families self-refer. So they're knocking on our door as their first point of entry in the community for help. There's a lot of community trust and parent trust in our program. Families tell each other about our service and recommend us to one another. And then you can see also referrals coming from other partner agencies, hospitals, and our public CPS. We deal with, so we are serving predominantly single female headed households of color. We are engaging co-parents and guardians whenever possible in our family preservation services. We always tend to have a few more boys than girls and are dealing with, as I mentioned, both on the parent and child side, both predominantly families of color. I'm sharing the age ranges because we talked about, nurseries that are running the gamut from birth through 18. There's also, I think, a misconception in many of our communities that these must be teen parents who just need that parenting support. And in fact, while we do go up to the age of, 13 and under 13, the majority of our children are still birth through 5. School age children tend to be an older sibling who often is co-parenting with a parent struggling with mental health or other crises themselves. But our parent community is primarily mid-20s through mid-30s. And you'll see on the far end a big spike in the 60 and over. More and more grandparents in our community are the primary guardian and caregiver for children and are seeking our support. And I apologize, for once it's sunny in Cleveland and I'm glowing on my screen. Last year, so, we've always talked about the kids in the nursery, the children we serve in the crisis nursery, but we're reaching so many more children and families. So when you look at the whole gamut of families whose lives the crisis nursery is touching, it was over 740 children and families in the crisis nursery program, our aftercare programs, our community parent programs, the referral program. We also do community giveaways in times of high need or at seasonal changes to support families that need those basic items to help their family remain afloat. And our results are pretty astounding. 100% of all of our families are surveyed in all of our programs, 100% feel supported. They're reuniting at extremely high rates compared to a lot of other programs. Interestingly, while I think again, the community perception is, well, these children are away from their parents, they're living somewhere else, it must be affecting that parent-child bond. 99% of our families say that their bond improved or stayed the same. In fact, 70% of our families reported that their bond improved through the engagement with our crisis nurseries. And you can see, 97% fully engaged in services, the high rates of improved stability, parenting skills, decreased trauma symptoms. These are all self-reported following services. One of our studies that was published in a national peer review journal, again, led by Dr. David Crampton from Case Western Reserve University, really set out to answer the question, do crisis nurseries prevent kids from entering foster care? And in fact, through the course of the study, we found, yes, that, even as we looked at our children against public system data, a high percentage of those children had remained out of foster care during the period. We also talked about earlier the success of minority families in this program, and we hope to dig into that a little bit further. Anecdotally, we believe it's that voluntary component of I've chosen to be here, and the really individualized approach that crisis nurseries can take with families, kind of steeped in cultural awareness and competence. One other thing we looked at was recidivism, which a lot of our programs say, we must have failed. They came back, they needed us again. And we found that while, almost 30% had multiple admissions during the period, they were no more likely to have foster care involvement at the end of services. And in fact, we encourage our families to come back and say, if you're feeling like it's getting out of control again, and we are the safest place that you have, come back. We embrace that because they found a place that can help them and they're keeping their children safe. We are, as I mentioned, talking with Dr. Crampton to continue a study of our impact on maltreatment reduction, family preservation, foster care prevention, and also community safety. Our facilities on our new East Side are in a very high-risk community, and we're already beginning to see some reduction, we believe, in some of the violence and community violence around that site. So hoping that we'll be partnering with our local police force to see if bringing in a nursery in the community can have a broader societal impact on community safety as kind of a haven in that neighborhood. We also do model and track social indicators, and we look at family stability indicators longer term. The framework was originally developed through another research group at Case Western Reserve University. We've continued to use their data model to look at the longer term outcomes. So impact on income, employment, housing, educational connection and attainment, engagement with medical services. So here looking at, that income, employment, and housing, and you can see we are seeing, a decrease in families who have no income, increases in employment, increases in income, and increases in families living independently in their own houses or apartments who were perhaps formerly homeless. So, we really highlight these because I think the assumption is nurseries are really just there about the children, and there's no lasting impact to the connections we make and this ongoing support for families. And this clearly, makes it apparent that this is a long-term impact for families. Lastly, I want to highlight and Amy Mills, who is our manager for this program. And we've, as I mentioned, got some friends from the Center for Crisis Nurseries. So a number of years ago, and thanks to Jill and Cassandra at a number of ARCH conferences nationally over the last 20 years that I've been involved in nurseries, they've always provided a track or an opportunity for us to meet and talk about the work we do, because many of us are the only one or one of two in our entire state. And as that conversation continued informally among nurseries, so gosh, it would be great if there was a way for us all to convene, to share ideas and knowledge and best practices. So about 2 years ago, we launched the Crisis Nursery community under the Center for Crisis Nurseries. And this is a live, collaborative, interactive portal where active nurseries and those interested in opening nurseries can come together to share ideas, share articles, videos. We also host monthly roundtable lunches together to really talk about best practices and coalition building across North America in our nurseries. We are currently working on the launch of the Crisis Nursery Institute, and this is a virtual learning portal where people can actually download materials. Some are free, some are at a small fee, that are best practices from nurseries publishing content that others might be able to use. Intake packets or policies, staffing plans, things like that. Really technical support in helping across the array of organizational structure and service delivery in a crisis nursery. And then replications and consulting services. So a lot of our startups or even nurseries that are operating want to layer in new elements. How do I bring family preservation into an existing nursery? Or I'm brand new, I want to open one. What is sort of the workbook to help me know how ready I am and what it's going to take to get started? And those are more individually coaching-based or consultation-based engagements through the Center for Crisis Nurseries. So that's kind of where the nursery community, we hope, is heading or is heading here in the next 12 to 24 months. It's been an awesome experience to engage folks from all over North America in these conversations and learn from one another. So I appreciate your time today. I appreciate, hearing a little bit more about Providence House. We're really proud to be a part of this level of care in the US. And I will open it up for any questions that anyone might have for me, Cassandra, Susan's on, Jill's on.
Great. Thank you so much.
Thank
for
you,
that-
Kim.
for that. Thank you for that great presentation. There have been a couple questions in the chat, so I'm just going to scroll back up to make sure I don't miss any. The first question I see is, what is the funding source for this model? Is it federally funded, or is it up to each state to fund it in some way?
So I can speak for the Providence House model, and I know that we've got Amy from Vanessa Behan. Her funding model is all private. At Providence House, it's somewhere between 70 to 75% private philanthropy. To give you a sense of the lift there, our current operation is about $4.3 million. It will be $6 million when the new facility opens. So we're kicking a big can in the community around us. And those are individuals, corporations, foundations predominantly. The balance of our funding is coming a little bit from our local county through those public agency contracts, but the majority is either federal pass-through to our state through Victim of Crime Act funding, or a specific line item that we've carved out for Crisis Nurseries in Ohio through the Department of Children and Family Services.
Great.
And I would like to just tag on to that for states that receive community-based child abuse prevention funding, respite is an authorized service that they can actually fund. So I recommend that, and some states I do know have used their community-based child abuse prevention money for respite, including crisis respite. So I would, if you need to know more about that, contact me and I can give you the contact information for finding out whether or not your state funds respite, and then how to advocate for that if they don't. So
Great.
that's
Thank
another
you so
source.
much. Great. And then Rebecca asked, can families utilize the services more than once?
Unmute. Yes, they certainly can. And for most nurseries that we've spoken to, they do. So about 25% of our families readmit in the same calendar year even. And so while our state allows 90 days per admission incident, children can readmit up to 120 in Ohio. And we see that frequently for families with their own chronic medical needs and treatment management. We will readmit during that treatment phase, and then the children will go back home. We also do see families that it might be 2 years between services. Maybe they now have a new baby or some new factor has played into their family's stability. So we've had families where we had an infant and 5 years later, mom comes back with that child and maybe 1 or 2 others. So again, we encourage families to seek our support if they find themselves in a situation where they need us.
Great. The next question I see is from Marilyn. How long does it take from when a family contacts you until they get services, including shelter for their child? Are some of the stays scheduled at a time?
Yeah, so while it says Crisis Nursery, 90% of our admissions are pre-planned. So the family knows an eviction is imminent. They know a baby is due to deliver. They know that there is something coming up for them and they're calling in advance. But we do have families who, they call in an urgent need or they're knocking on the front door and are trying to immediately triage that family and provide services. So the answer is, it depends. If we don't have a waiting list, which is hardly ever, we can get them in right away. If we have a waiting list, then we're triaging that waiting list. Just because you're the first call doesn't mean you might be the first one admitted. There might be some other factors around how many girls we can have, how many boys, how many babies, all those factors come into play. I would say on average, children on our waiting list are waiting 7 to 10 days, but the family is receiving basic need items and case management support during that period of time.
Great.
And I've had conversations with different crisis nursery providers, and when they can't serve someone immediately, which of course, if you're just in a car accident and you're in the hospital and you have 2 children, it's an immediate need. But if a program can't serve a family immediately, they will often make sure other services are in place. So they make sure that no one is left high and dry. But ideally, a crisis nursery, they've thought about these things in advance. What are we going to do when a crisis happens and we don't have space in the nursery? So
Great. I also just want to call everyone's attention to some of the great links and resources that have been posted in the chat. So please take a look at that. And then I see a new question here from Lindsay. What kind of outreach do you do to promote your visibility in the community?
So from a client perspective, we certainly are reaching out to those referring partners. So regular presentations from our social work team with local CPS, local mental health or sobriety programs, employment programs. So they know who we are, they know we're there for families, and that we might be calling them for help with our families. We also do a lot of community fairs where families are encouraged to attend or receive information about community services. So we're out in the family populations. And we've recently formed a parent advisory board of parents who have moved on with our program, who are a part of now our decision-making process. They're helping us evaluate program outcomes, making recommendations about how we further reach out in the community and let families know that we are a resource to them.
That's great. I'm not seeing any other questions in the chat right now, so if other folks have questions, please share them or feel free to unmute if you have a question. I just wanted to call attention and ask a question for Dr. Crampton. I see he's on the call and video's on. So what I love about this is the great collaboration you have with Case Western and the academic research partnership with the Providence House. And that's really what the Break Exchange is all about, is promoting those collaborations. And so I'd love to hear a little bit about, from your perspective, how that's going, or if there's any tips or advice you have for others who are looking to seek academic partners for evaluation and research initiatives.
Well, I think Natalie hit on this, but a big part of this research has been the issue of institutional racism. And actually, our local public child welfare agency in their mission statement says we need to do a better job of addressing disproportionality, we call it. So 30% of the children in Cuyahoga County, where Providence House is located, are African American, but well over half the kids reported for child abuse are African American. And as you go through each stage in the process, from referral to investigation to removal to permanent custody, the proportion grows greater. And I think I can say they honestly want to do a better job with this. And I've been trying to say to them, look over here. Providence House is like keeping African-American kids out of foster care, which is your goal. And I can assure you that the workers on the ground know this. And as Natalie just said, I mean, they tell families, why don't you call Providence House? And so I put in the chat, Dorothy Roberts has just written this book, Torn Apart, which is her case for abolishing the public child welfare system. So if you're not familiar with it, I would suggest you check it out. Most people go, oh, wait a second, if we get rid of the public child welfare system, what's going to happen to all those at-risk families? And I think part of our response can be, well, for example, Crisis Nursery, for example, Providence House in Cleveland, Ohio. So what interests me personally is the way that this research contributes to the conversation about racism in the child welfare system. And I mean, we don't have time to get into that today, but that's one of the things I'm interested in. And we have an opportunity because Providence House is going to open a new facility in a very challenging part of our community. And so it presents an opportunity to ask the question, what happens in that community when they open a new site? And I'm very excited about this because I think, as Natalie said, we've already started talking with the police about, well, not only will it reduce foster care placements from that neighborhood, but it could reduce crime. It could reduce interpersonal violence. Natalie didn't really touch on that, but my sense is that in some cases, maybe clients don't come right out and say this, but what they're trying to do is extract themselves from a violent relationship. And, maybe they're dealing with a batterer who uses their own children against them. The ability to put your kids someplace where they'll be safe for a short period of time may allow you to then take the steps you need to get out of that relationship. I just think that's really cool. And when we have this conversation about like our inadequate response to interpersonal violence, particularly in minority communities, again, we can say, we know calling the police is not exactly what they want to do for obvious reasons. Here's an alternative model. So in my opinion, we should lift up crisis nurseries as not only the great things that Natalie described, but also it's an anti-racist strategy. It's a foster care prevention strategy. It's a interpersonal violence strategy. So that's kind of the reason I like to do the work with Providence House, because they're doing extremely good work and I'm interested in what they do. And if I may say, many of my former students work there.
That's great. Thanks so much for sharing. I do see 2 questions in the chat. Elaine asks 2 questions. What was your experience during COVID? For example, a parent is hospitalized and a child needs care. And 2, how does this work with medically complex kids in need of DME or other supports?
So I can, from the Providence House perspective, so they would reach out to us, and we have had hospitals outside of COVID even, where a parent is hospitalized, even in an emergency situation, and they've got young children, where we have admitted the children. So there are forms that we use if a medical provider, or we consider them first responders, is admitting on behalf of an incapacitated parent. So we have, worked that process out with our state licensing and our local first responder community. With the children who have complex medical needs, we do have a medical director. Our pediatric services are contracted through our local county hospital. They are a pediatric medical provider. So they will assess the needs of the child before we admit them to the crisis nursery to make sure that this is home health level care. It is not requiring hospitalization. So we'll vet each case independently. If the child is a child that we can care for, and we partner with them for things beyond the assessment and ongoing monitoring, for injections, tube feeds, oxygen, things like that, they'll come in on a PRN basis and deliver that level of care to the children in addition to the medical oversight. So I hope that answered the question.
Great. And then one last question, and then I think we'll wrap up for those who have a hard stop at 11. A question from Tiffany. There was a slide on increasing family stability. Have you used a specific curriculum to increase family stability?
So there are a couple of family stability indicators that we use. So our tracking system, we actually developed with Case Western on the benchmarks that we do track. And we're scoring families from the point of intake throughout their weekly check-ins and throughout their twice monthly check-ins and aftercare. So that experience window could be as long as 18 months for our families. We also, in terms of how we work on stability for families on the parenting side, we use 6 different evidence-based parenting curriculum based on the parent's needs, self-identified or observed. We bring in materials from those evidence-based resources to deliver a very unique, focused on the parent, parenting education plan. And then we work with our families through weekly crisis counseling sessions where we keep peeling the onion, if you will, to identify the supports that they need in that wrap model. So we're connecting providers to the family throughout their stay with us to ultimately create that safety net that they're going to need long-term.
Great. So I just want to call your attention to the chat. There is links to the past recordings of Break Exchange webinars where this recording will be, as well as the ARCH website. And want to just thank you again to our presenters for this great conversation, to all those who attended. And we will officially end the webinar, but if there's people that do want to stick around to ask some additional questions, I'll keep the link open for a little bit longer, as long as the presenters are able to stick around. So thank you again for attending today's webinar hosted by the Break Exchange and ARCH, and hope that you guys all have a good rest of your day.